Right, everybody. Good evening. We're going to get started here. It's 6 o'clock by my watch. I just wanted to welcome all of you. I appreciate you all attending this evening's medical discussion about preventative care and breast health. We have Dr. Annabelle Vera Panini with us here. She is one of the oncologists at the brand new Northwestern Medicine Oak Brook Oncology Center. And she is here to share her expertise with us. I will be monitoring the chat, letting people in and out of the lobby as they come in. So if you guys have any questions, feel free to post those in the chat, whatever you want. Or if you want to unmute at the end and we can take questions, whatever works best. So I'm going to let Dr. Vera Panini take it away and let me know if you guys need anything.
All right. Thank you, Ashley, for that really warm welcome. I just wanted to say thank you very much for giving me the opportunity to present this evening. And all right, here we go. So I was requested to present on preventative care and breast health, and I wanted to just cover a number of different topics, including exactly what is breast tissue, what is breast cancer, screening for breast cancer, risk factors for breast cancer, and what are areas of improvement that we can work on. So breast tissue is composed of the lobules, which are the glands that produce the milk, ducts, which are the tubes that carry milk to the nipple, and connective tissue, which consists of fibrous and fatty tissue, and this holds everything together. The majority of findings that are consistent with invasive cancer usually resemble the cells that line the ducts, approximately 90 to 95% of the time. Less than 5% of the time, the invasive carcinoma cells may have a similar appearance to the ones that line the lobules, and then less than 1 to 2% involves carcinoma of the connective tissue. So when we talk about what is breast cancer, under usual circumstances, there's a single layer of cells that line the duct. And under usual circumstances, every cell in our body is programmed to grow and divide through this very tightly regulated process. And if one cell undergoes a change or a mutation, it gains the ability to start doing things that normal cells cannot do. So when these cells start to proliferate, they may enhance or they may develop these changes that lead to what's called ductal carcinoma in situ, or DCIS, which is non-invasive carcinoma. When it's identified at this stage, this is when we call it stage 0. If these changes continue to proliferate and these cells are allowed to invade through the basement membrane, that's whenever we find these changes consistent with invasive ductal carcinoma. So we frequently get asked this question, but what exactly is cancer? So the word cancer, by definition, means uncontrolled cell growth. Cancer can start almost anywhere in the body. As I mentioned, under usual circumstances, cells grow and divide to form new cells as the body needs them. And when these cells become old or reach a stage called senescence, or they become damaged, they die and then new cells take their place. So when cancer occurs, this orderly process breaks down and abnormal and or damaged cells multiply and divide when they shouldn't. Malignant or cancer cells also have the ability to do things that normal cells do not. Normal cells respect boundaries, they don't invade adjacent structures, they serve their purpose, they recognize when they've reached that limit of growth and division, and then they go away. Malignant or cancer cells have the ability to invade or spread into adjacent tissues or travel to distant places in the body, and we call that process metastasis. So when we talk about the term cancer, the father of modern medicine, Hippocrates, in about 400 BC, was considered the first person to use the word cancer to describe tumors. The word cancer is derived from the Greek word karkinos, which means crab. So when he was observing individuals who we believe had advanced stages of cancer, he was probably referring to the appearance of tumors. So the main portion of the tumor was considered to be the crab's body, and the various extensions of the tumor were considered as the legs and claws of the crab. So that's where the term is believed to have come from. As I mentioned, under usual circumstances, cells grow and divide through this process called mitosis. And this is a depiction of a normal gene up here in the top left. Now, genes encode proteins. Proteins are considered the workhorses of our body. They execute functions that allow for our body to operate normally. If a gene, which again is the blueprint, if you will, or the instructions that give directions on how to make these proteins, if a gene is damaged, we no longer have the ability to give proper directions. And what's produced is either an abnormal protein or no protein at all. And as a result of this, then the cell's functions become disruptive, and cells then are able to grow and divide in a manner that is abnormal. Here on the right, we can see the result of chromosomes, which are intact, and then that leads to development of a healthy cell. Whereas if chromosomes are quote unquote broken because these genes are abnormal, that may lead to changes within a cell that then allow for them to become cancerous. So just to review, the differences between cancer cells and normal cells. Cancer cells grow in the absence of signals telling them to grow, and they ignore the cells that normally tell them to stop growing or dividing. And this normal process is called programmed cell death or apoptosis. As I mentioned, they invade into nearby areas and they spread to other parts of the body. When cells start to grow and divide and then develop a mass, they start to suffocate and they lose their blood vessel or their oxygen supply. So they have the ability to tell blood vessels to grow towards these tumors, and this allows for the blood vessels to supply tumors with oxygen and nutrients. Cancer cells also gain the ability to do things like hide from or trick the immune system. As I mentioned in the previous slide, they accumulate multiple changes in their chromosomes, and they can utilize nutrients in a different way than normal cells do, which allows cancer cells to grow more quickly. In contrast to cancer cells, normal cells only grow when they're supposed to, whenever they receive these signals, and they only grow when they're instructed to do so. As I mentioned before, it's a very tightly regulated process, and if mistakes happen during that growth and division, there's opportunities for the cell to repair itself, or if there is damage beyond repair, then the cell is programmed to go through that programmed cell death or apoptosis. Normal cells also do not invade other tissues, and they stop growing and do not move to other parts of the body. So here you can see the depiction between what normal cells will do, where they recognize there are barriers here. They really don't invade the boundaries surrounding them by the other normal cells, whereas cancerous cells continue to multiply and divide, and then they start making their way through these basement membranes and invading adjacent tissues. And of course, under the microscope, they look very abnormal. So the growth and division of these cells, here we have a cell which starts to replicate some of its information. If you go back to your high school biology class, this is the normal cell cycle. The cells are programmed to go ahead and create an identical copy of its genetic information. It evenly divides it between two daughter cells, and the two cells split into two. So regulating these processes involves different types of genes. One type is called a tumor suppressor genes. These are the negative regulators of the cell cycles. And then there are these proto-oncogenes, which enhance or push the cell cycle forward. So under usual circumstances, it's really important that these genes are programmed to work correctly. And you may ask, well, why do we have positive regulators of the cell cycle? And it's because if we develop from small children into adulthood, or if we hurt ourselves and we need to heal a wound, these proto-oncogenes in usual circumstances are put in a stop position. But when they recognize that cells need to be replaced because we need to heal or because we need to grow, mature, develop, then they will push the cell cycle forward and allow for normal cells to develop. On the other hand, these normal tumor suppressor genes, they stop the overproduction, the overproliferation of cells, and they recognize that we shouldn't allow for these cells to grow out of control. So it's very, very important that both types of these cells are present and that they're functioning the way they should. What we believe and understand happens is that when cancer occurs, both copies of these tumor suppressor genes are damaged, and so there no longer is the production of a protein. Remember, I mentioned that proteins are the workhorses of our cells. And so what happens is if these proteins are no longer made, this cell cycle is allowed to continue moving forward, and these cells grow and divide without any appropriate breaks in the system. Similarly, if a proto-oncogene is mutated where the switch is jammed on, it gains the function to be able to produce more of these proteins that then push the cell cycle forward. And as a result of one or both of these issues happening, usually it's one, usually it's a mutated tumor suppressor gene, which leads to the first initiating event, then that's whenever we develop cancer cells. So here's another depiction of normal genes where we look at the tumor suppressors in healthy tissue. They're sort of like the brake working in a car. You want to make sure that you can stop things from going out of control. And the proto-oncogenes that are in charge of pushing that cell cycle forward and allowing for growth and division of cells, in usual circumstances, this accelerator is mostly off. What happens is that in mutated genes, the tumor suppressor genes, the brake is no longer working or it's defective. And in the oncogenes, instead of being mostly off, something has jammed it on. So another way of looking at it, if we're looking at the oncogenes where the accelerator is jammed, here we have a depiction of two genes. So we inherit one copy from mom, one copy from dad. And in the proto-oncogene scenario, if there's a mutation in this particular gene that allows for it to mutate and become an oncogene, this drives everything forward and allows for accelerated cell division. And as a result of that, we develop cancer. When we talk about the tumor suppressor genes, again, these are the ones that regulate cell growth. So one copy from mom, one copy from dad. And as we go through life, if there's damage to the first copy, we still have this other unaffected copy, or what we call the wild type copy, to be able to carry out the function where the proteins are being made and things are under control so far. But if that second copy becomes damaged as a result of exposure to other things, then we no longer have this break on the cell cycle, and it allows for everything to push forward and we develop cancer. So there are a number of different genes that are involved in the development of malignancy. I'm going to bring up another model. I know this is a talk about preventative care in breast cancer, but just to give you an idea, because we get asked these questions a lot in clinic, I just wanted to bring up the idea of screening in colorectal cancer. So here we have normal epithelium, which is the lining of the colon. And what we understand is that the loss of two copies of the tumor suppressor gene, APC, allows for this normal epithelium to start proliferating quite a bit. And then as time goes on, we can develop a benign polyp within the colon. Then we understand that the second mutation that can occur happens in an oncogene. So remember I mentioned that only one mutation has to occur in a proto-oncogene, and it becomes an oncogene, and this pushes everything forward. So now we've got the loss of these two tumor suppressor genes. This oncogene KRAS is now mutated. It starts to allow for further growth and development of these abnormal cells, which is not still the benign polyp, but we just know that that shouldn't be there. Following that, we have additional mutations in this tumor suppressor gene called DCC. Now we start developing all of these polyps within the colon. This polyp starts to get bigger. And then usually what happens is this tumor suppressor gene called P53, which is also considered the gatekeeper for cell growth, once that becomes mutated and the changes within these cells start to allow for really, really abnormal and accelerated growth and division, that's when we develop carcinoma. And as additional mutations develop, these cells start to gain the ability to do things that normal cells don't over here. Normal cells will, again, respect boundaries, stay in their place, grow and divide. And when they reach that point where they recognize, I shouldn't be doing this anymore, they reach that point of senescence, and then they apoptose and go away. Here, on the other hand, these cells are very, very abnormal, and they gain the ability to metastasize. So it's really important in something like colorectal cancer where we're screening, because we want to find these abnormal polyps early on before they become invasive and before they start to gain all of these mutations. Because what we understand is that once a cell becomes mutated, it allows for additional mutations to arise. This scenario that I'm demonstrating here is considered the clonal evolution model, where When one cell develops mutations, one single cell can then start to acquire additional mutations and progresses in a linear fashion, and they gain the ability to survive a little bit more. So, this particular model allows for us to understand the reason why it's very important to know that if we catch these adenomas early on before they transform into a carcinoma, we can treat this at an early stage. Another issue of note is that it's not just one cell that undergoes mutation. They've done other studies where they look at DNA damage within one particular cell. Here we find this cancer cell, which is one clone, but then this clone is allowed to go ahead and develop additional mutations and then starts to beget additional other mutated cells, whereas the normal cells, the unaffected cells, are sitting there, and as these other abnormal cells then continue to acquire additional mutations that allow for them to grow, instead of in the previous slide where you saw one cell coming up to become a cancerous tumor mass, here you can see that there's different types of clonal cells that are developing. And these are all different populations of malignant cells. So when we biopsy something, the concern is always that we may be biopsying only a certain population of these cells instead of understanding exactly the entirety of the entire tumor. So this is what we call the branched mechanism, where one cell can develop other additional clones, which then move forward to develop additional clones. So you may ask me, well, why are you talking about cancer? And that this is kind of like a biology class. And why is this important for me to know about preventative care and breast health? We know that the mutation sequence in breast cancer, unlike colon cancer, is not well delineated. It's still being studied. But I hope that I can help you understand why screening and detecting cancer early is so very important. Because we understand that the larger a tumor becomes, the more likely it is to suffer the next mutation. And this is because of the probability of a mistake happening where a proto-oncogene can be jammed on, or damage to tumor suppressor cells may happen. And the longer we live, the more opportunities there are for mistakes like this to occur and accumulate in our genes, which is why it's really important for individuals to start screening at the age appropriate time, whether it's breast cancer, colon cancer, and so forth. And there are greater chances that mistakes may happen. And while when you really look at everything, the odds of that happening are pretty small. But when you think about the number of cells that we make in our lifetime, the opportunities still arise for mistakes to occur. So here we look at a normal breast duct. As I mentioned, there's a single layer of cells that line the lumen. And what we do understand is if that one of these cells undergoes a change or a mutation, hyperplasia, which means abnormal cell growth, may develop. And as these cells start to grow, they may acquire these changes or mutations in themselves, which may lead to atypia. Atypia means that things are not looking normal. It's not just hyperplasia where there's too much growth, but now it's too much growth with abnormal changes within the cells. If this continues to progress, the natural progression of it would be the development of non-invasive cancer, DCIS, which is stage 0, as I mentioned before. And then when these cells continue to acquire the ability to invade through that basement membrane, that's whenever we call it invasive breast cancer. So while the changes in the genes may not be well delineated the same way they are in colon cancer, we do understand that this is the usual progression of atypical cells developing, first with the hyperplasia, then with the atypia happening, development of non-invasive cancer, and then the acquisition of changes to allow for abnormal invasion into tissues they should not. So this is why screening and detecting cancer early is so important. We need to understand that the larger a tumor becomes, the more likely it is that the tumor cells will acquire the next mutation. So screening is really important. So what is breast cancer screening? It means we want to check the breast tissue before there are any signs or symptoms of disease. And the gold standard really is a mammogram. We get asked this question all the time. Well, shouldn't I undergo maybe a breast MRI or an ultrasound instead of a mammogram? And the answer is no. Mammograms are X-rays, X-ray images of the breast tissue, and they are really the only imaging modality that has demonstrated a decrease in breast-specific mortality when we look at randomized clinical trials. When we look at other imaging modalities like ultrasound and breast MRI, what we understand is that these are adjuncts, meaning that what can we utilize in terms of imaging the breast tissue to augment the findings on mammogram. And I'll go through the indications for each of these. And then also, I wanted to touch briefly on the role of breast examination. So in years past, there was this push for clinical breast examinations to be done for screening, both in the clinic and then for patients to also examine themselves. What we understand now is that as part of a screening, most guidelines really don't encourage clinical screening breast examinations. What they do encourage are diagnostic clinical breast examinations by the clinician if there is awareness of the individual that something is abnormal within the breast. Certainly, some practitioners will continue doing the screening clinical breast examination as part of a comprehensive well woman check. There's certainly nothing wrong with that. It's just that we understand that we need to ensure patients continue to undergo mammograms because that really is the gold standard if we're talking about screening for breast cancer. Women also should be aware of changes within their breast tissue because we're probably the most knowledgeable about any changes because we have them. And it would be advisable for women to be aware of it, but societies and guidelines don't necessarily encourage self-breast examination for breast cancer screening. When we talk specifically about checking the breast tissue before there are signs or symptoms of disease, I really have to emphasize the importance of mammogram and that we augment the findings on mammogram with other imaging modalities like ultrasound and breast MRI, as well as understanding the changes within the breast tissue by either an examination from a clinician if something is already identified, or if a woman notices that there are changes within her breast. So here we have a picture of a mammogram, which, as I mentioned before, is an X-ray image. This woman is postmenopausal. She has very fatty breast tissue, which makes it readily imaged. If there were development of a mass, that would be easily identified. When women are younger, if they have dense breast tissue, sometimes mammograms can be challenging to read. But I just want to give you an example of what a typical postmenopausal woman's mammogram looks like when she has very fatty breast tissue, making it much easier to visualize any potential masses. So what to expect during a mammogram? A patient would fill out a pretest questionnaire, and then each breast would be compressed horizontally between two plates for imaging. And then each breast would be compressed diagonally between two plates for imaging. And you may wonder, well, why does this have to happen? These are not exactly the most comfortable things to go through. And the reason why is because it allows for us to acquire additional imaging from different viewpoints. And this allows for us to better visualize the breast tissue. So when the breast tissue is compressed horizontally, it allows for visualization in what we call the craniocaudal view. So this is looking from above and below through the breast tissue this way. Again, this is a postmenopausal woman with fatty breast tissue, which makes it much, much easier to visualize any potential masses or calcifications. When the breast tissue is compressed diagonally, it allows for us to obtain what's called a medial lateral oblique view. So here you can see the axillary region, and we can visualize the breast tissue this way. So it's really important that we get great images from both vantage points because it allows for us to visualize breast tissue and assess for abnormalities. So this demonstrates the importance of capturing breast tissue in both views. On the right, we have this craniocaudal view. So this is when it's compressed horizontally. And this arrow is pointing to a mass. This bright white spot is a clip. And this is what was identified as the abnormal finding on the mammogram. But when you look at the medial lateral oblique view, you can't visualize it. So it's really, really important that we have adequate imaging in both of these views so that way the physicians can determine what needs to be acted upon. Breast ultrasound, as I mentioned, is another imaging modality that augments, or we use it as an adjunct, something in addition to mammography to be able to identify any abnormal findings within the breast tissue. So here we have a transducer. They'll put gel on the chest wall, so that way we can allow for sound waves to come through and identify any abnormalities within the breast tissue that were identified on mammogram. Here you can see different shapes of different things that we can find within the breast tissue. When things are round or when they're oval, most of the time with these smooth findings, it's usually something benign. But when we find something with these irregular margins, especially with shadowing behind it, that's when we get concerned about something, and usually recommendations are made for biopsy at that point in time. We'll get asked all the time about using ultrasound as a screening modality, and we don't really use ultrasound. It's how I should phrase that is it's inadequate as a screening modality. Mammography really is the gold standard, and we can always augment and add imaging based upon findings on mammogram with ultrasound. So breast MRI is another imaging modality that we utilize to evaluate breast tissue. What you can expect during a breast MRI, you would be given a contrast agent called gadolinium, and then an individual would lie down on a table outside of the scanner, and the breasts are placed in the hollow spaces in the table. The table would slide into the scanner for imaging, and the images are created by the changes in signal whenever there's movement of magnets, and it allows for movement of protons. There are signal changes between protons of fat tissue and water, and that's actually what gives us the creation of an image. And patients will ask, well, should I get a breast MRI? And this really is an adjunct in addition to breast mammography, specifically for those individuals that are considered high risk, which by definition are those individuals who, based upon risk calculation models, would have a lifetime risk of developing breast cancer greater than or equal to 20%. As I mentioned before, for a breast examination, really we want to use this as an adjunct. Diagnostic clinical breast exam is important. So if a patient comes in and says, I feel something in my breast, for a clinician to do the breast exam at that point in time is very important. As a screen, again, it can be done during a comprehensive well woman health check, but as part of the screening process for breast cancer, it's not really recommended. In terms of self-breast exam for awareness, we believe that it's important for a woman to be aware of any changes within her breast tissue, but most updated guidelines don't really recommend self-breast exam as the modality for breast cancer screening. So I just wanted to make sure that I emphasized why these things are important to be aware of in terms of breast cancer screening. We want to make sure that we emphasize the use of mammography on a scheduled routine basis. So in terms of breast cancer screening, and when we talk about risk categories, what we're talking about is the lifetime risk of being diagnosed with breast cancer, not dying from breast cancer, but being diagnosed with it. So most women are really average risk. And when we say average risk, we mean less than 15% of being diagnosed with breast cancer. We understand that 1 in 12 women will develop breast cancer by the time she reaches her 80s. That's including both non-invasive as well as invasive breast carcinoma. So most women fall into this average risk category, and mammography is the gold standard, as I mentioned. The National Comprehensive Cancer Network, which Northwestern is a part of, recommends annual mammography for all of these women. When we talk about moderate risk, we're talking about a 15 to 20% lifetime risk of being diagnosed with breast cancer. Women who fall into this category may include those individuals with a first-degree relative who have breast cancer without a known pathogenic mutation or gene susceptibility or cancer, hereditary cancer syndrome. So a woman who has a first-degree relative, a mom, a sister, a daughter, may be in moderate risk of developing breast cancer because of her family history without any gene mutations. When we talk about high risk, we're talking about greater than 20%. This category would include those women who have a known pathogenic variant in a susceptibility gene like BRCA1, BRCA2, PALB2 is another one. we also have these risk models, which can help determine if a patient would be greater than average risk and may benefit from the utilization of breast MRI in addition to mammography. So for those women in this high risk category, we usually recommend mammography on an annual basis, augmented by breast MRI. And each of those modalities would be done every 6 months. Each modality would be done once a year, but at 6 months apart to allow for breast imaging at a 6-month interval. For moderate risk individuals, it would be an annual mammogram. So we actually group these two categories together, average risk and moderate risk. So even if a woman has a first degree relative or is considered moderate risk, we would still use annual mammography. And if we feel like we need to augment with ultrasound, we would do that. Breast MRI really is indicated for these individuals within the high risk category group. So talking about determining risk, as I mentioned, history can really play a role. So we understand that those individuals with a personal history or a family history of breast, ovarian, fallopian tube, or peritoneal cancer, that really may strongly indicate the potential for a hereditary cancer syndrome or a mutation in a gene like BRCA1 or BRCA2. For those individuals of Ashkenazi Jewish ancestry, we understand that there's the higher likelihood of finding certain pathogenic variants in genes like BRCA1 or 2 within these populations. So that's another thing that we want to take into account. I've covered this part. We understand mammographic breast density can also play a role because the higher the breast density is, that is a known risk factor for potentially indicating a higher risk of breast cancer. So for these individuals, we want to make note of the breast density and then sometimes augment with what we call ABUS or automated breast ultrasound in addition to the mammogram. When individuals have previously undergone a breast biopsy and are identified with a high-risk breast lesion like atypical hyperplasia, we also want to make sure that we take that history into account. Other things that we also note are whenever a woman has started age at menarche or her first period, how old she was with her first live birth, the number of pregnancies she's had, and then how old she was when she went through menopause, because we understand the exposure to estrogen and the cycling that women can go through may potentially be a determining factor in terms of risk for breast cancer. And then for those individuals, like say, for example, an individual who's diagnosed with perhaps Hodgkin's disease at a younger age, if she had undergone radiation to the chest in her younger years, that radiation exposure can also increase the potential risk for developing breast cancer. I briefly just wanted to mention these risk prediction models. These are utilized in high-risk breast clinics. Sometimes they can be used in primary care, specifically the Gale model. But these are different calculations that we can use to help determine an unaffected individual's risk of developing breast cancer over time, and if she would meet criteria for adding a breast MRI to her annual mammogram. They also have specific models for those individuals that are known to carry these gene mutations like BRCA1 or BRCA2, and I just wanted to briefly mention those here. So there are certain risk factors we cannot change. We know that, as I mentioned in previous slides, as we age, there's more opportunity for mistakes to happen with regards to cells growth and division, leading to cancer. We understand that family history plays a really big role. Even if there is no, even in the absence of a gene mutation or a hereditary cancer syndrome, if a family history is very strong for cancer or breast cancer itself, we understand that that can increase the potential risk for an individual. I mentioned dense breast tissue also being a risk factor. And then there are other issues that we do have a little bit more input from our own individual standpoint. We understand that if we follow poor nutritional habits and we start to gain weight, that can also lead to other systemic inflammatory issues like the development of things like heart disease and diabetes. We also understand that exposure to hormone replacement therapy may also potentially increase the risk for malignancy later on. And then certainly lifestyle choices like smoking, the amount of alcohol being consumed, or whether or not we move. Physical inactivity is known to increase systemic inflammation, and we understand that lifestyle choices like this can potentially increase the risk for cancer. What I wanted to highlight were the development of chronic health issues, specifically heart disease. Here we are in February, which is American Heart Month, and I wanted to emphasize the intersection of risk factors for breast cancer in addition to heart disease. What we do know is that we just talked about these shared modifiable risk factors for breast cancer: tobacco, obesity, physical inactivity, poor nutrition, alcohol, and diabetes. All of these things can lead to breast cancer, but what I don't think a lot of people understand is that while they also increase the potential risk for cardiovascular disease, we do have an opportunity to optimize what can we do about these particular risk factors so we reduce the risk of both of these, because they do overlap. And what we have to understand is that when individuals have cancer and we have to treat them, if they already have development of cardiovascular disease, it can really make it very challenging for us to safely treat these individuals with the cancer with curative intent. By the same token, individuals who have cardiovascular disease and they've developed all of these systemic inflammatory changes that can then lead to heart issues, if they develop cancer, it can make it very challenging to safely administer medication. So it's really important to understand how these areas intersect, and that it's really, really important for individuals to follow with their primary care doctor and try to do what they can to optimize their overall lifestyle, understand what they're being treated for, understand why they are taking certain medications, because what we want to do is decrease the risk of both cancer and heart disease. Breast cancer is the number one cancer diagnosed in women, but the number one killer of women in the United States is actually heart disease. Here's another diagram. This is a Venn diagram looking at the intersection of risk factors for cardiovascular disease as well as breast cancer. And as you can see, again, there are different things that we can't change, like age and family history. But what we can change are things like our nutrition, how much alcohol we drink, what our weight status is like, specifically with regards to central adiposity, or the weight that we distribute around our midsection. The level of physical activity, as well as tobacco abuse. So I'm hoping that I'm doing a good job of emphasizing this, because I tell patients all the time, we really want to reduce the risk of both of these diseases for women. Here's another way of looking at everything. Most of the arrows really go in the same direction. The only things that may be opposite, we understand that premenopausal obesity may increase the risk of cardiovascular disease. There's some thought that maybe it decreases the risk of breast cancer, but in general, obesity really is something we want to avoid. Smoking can really increase the risk of both heart disease as well as breast cancer. We understand that following the typical Western diet with lots of processed foods, lots of refined carbohydrates, that can increase the risk of cardiovascular disease as well as the risk of breast cancer as well. And then, as I mentioned, the whole idea of being exposed to cycling, ovarian cycling with fluctuating levels of hormones like estrogen and progesterone. The earlier an individual starts her periods, then that can potentially increase the risk for both heart disease as well as breast cancer. So Angelina Jolie, it's been about 11 years since she made the announcement. Her mom was diagnosed with breast cancer and died from it at the age in her early 50s. I want to say it was around age 52. And she had made the decision, the actress did, to go ahead and undergo bilateral risk reducing mastectomies, because she recognized that she was identified to be a carrier of this BRCA1 gene that predisposes her to developing breast cancer. And what she said was that it is possible to take control and tackle head on any health issue. You can seek advice, learn about the options, and make choices that are right for you. Knowledge is power. And I really, really love this quote, because I couldn't agree more. I think that the more knowledgeable individuals are, that they can make the right decisions about how to best take care of themselves in conjunction with their healthcare team. So we really have to work together when we look at, from a system standpoint, insurance coverage and government programs. We want to ensure that individuals have adequate and equitable access to healthcare for things like healthcare maintenance, treatment for acute and chronic illness. As we went over in the previous slides, the intersection between heart disease, I mentioned diabetes, as well as the intersection with breast cancer there. We want to make sure that individuals have the ability to undergo age-appropriate cancer screening. So when we talk about cancer screening, we're talking about access to not only mammograms, but also screening colonoscopies, pap smears for women, and then for also those individuals who have risk factors for lung cancer, making sure they have access to lung cancer screening CT scans. So areas of improvement here would include bridging that knowledge gap between insurance providers and patients. Patients should be allowed to understand what they should have access to. They should be allowed to ask questions about eligibility for certain things and make sure that they get what they need. In terms of healthcare systems, same thing. Adequate and equitable access is really, really important. And I think a major area of improvement that we all need to work on is being able to bridge that knowledge gap between healthcare providers and patients. There's a lot of terminology that we use in healthcare that individuals may not be familiar with. And by the same token, individuals, we would hope would also understand what kind of medications they're taking, why they're taking them, which brings me to the next part about patient engagement. I think it's really important that individuals understand the how and the why of their medications, also being familiar with their family history, because that can really have an impact on things that they're at risk for. And then being engaged with not only the healthcare provider, but also the system, and then just making sure they understand what they need in terms of coverage. So there's a lot of different things that we need to work on to ensure equitable and adequate access to healthcare. So in summary, I know I started off with a biology class, but I get asked these questions all the time during clinic about what is cancer? Why did I get this? And I hope I helped explain that just simply being a person, simply having the tissue, going through life, the natural growth and division of cells to replace other cells that have fulfilled their function. Sometimes mistakes can happen and genes can go awry. So in order to catch things early, whenever those situations do occur, it is really, really important that everyone gets screened early. So I'd encourage everyone to get their mammogram. I would encourage everyone to continue their close follow-up with their primary care provider. Please know your personal and family history, be familiar with your medications, and stay engaged with your primary care provider. And with regards to room for improvement, I think we can all work together to ensure adequate and equitable access to health. So with that, I just wanted to say thank you very much for giving me this opportunity to present, and I'd be happy to take any questions.